is a member-supported nonpartisan organization which neither supports nor opposes political candidates or parties at any level of government. The League continues to encourage informed and active participation in government as it has done for 100 years. We work to increase understanding of major public policy issues and to influence through education and advocacy. It's in this spirit that we are here tonight. And it's all about healthcare. The League's universal health care position was published almost 30 years ago. It states in part that the basic level of quality healthcare at an affordable cost should be available to all US residents, and the League favors a national health insurance plan financed through general taxes in place of individual insurance premiums. It's become clearer than ever during this year of COVID how healthcare in the United States is unequal and the price we all pay for this. It should be noted that the healthcare is only one aspect of health. Turns out health is dependent on societal determinations, including social status, wealth, income, housing, education, environmental exposures, employment, family and community stability. In all these ways, we need to strengthen our resolve to achieve the greater equality in health that we all aspire to. Universal access to healthcare is the missing link in our ability to achieve this goal. Our presenters this evening will shed some more light on the history and current status of this effort. So I would like to now share with you, I kind of wanted to say a few things first so that everyone would get on board. Here's the Zoom rules of the road for this meeting tonight. It's a webinar, so you can see us, we can't see you. And if you want to send questions to the presenters, which we have factored in for Q&As throughout the evening, use the chat box at the bottom of your screen. And you can also look in the chat box and there'll be information posted to share with you, so from us. And here's the agenda. It's a tight agenda, and I think I'm already running over just a hair. So so with that, I have information. This is my last slide. I don't need to show that yet. I'm going to stop my share and we'll start with our first presenters. So I want to thank all the presenters for being so courageous as to do this evening with us. Our first two presenters, I'm glad to say, Steve Bach and David Loud. Steve is with Puget Sound Advocates for Retirement Action, as is David. And Steve is their vice chair for outreach. And David also represents that organization with Healthcare as a Human Right. So I think with that, Steve and David can take it away.
We've had a real test of our healthcare system in the last year, as we all know. And I think we're all aware of some of the ways where were before that our healthcare fails, in the number of people that are uninsured, the high cost of insurance, that we don't live as long as people in other industrial countries and have higher infant mortality. But there are a whole lot of other ways that our healthcare system has failed us in this pandemic. It's really been two factors. First is political failures, and we won't talk about the political failures that have caused us to do so badly in the pandemic. And the other is the holes in our healthcare system. And I want to focus on some holes that may not be as obvious, because if we want to move forward with the kind of healthcare we need, I think we have to highlight what people are experiencing, give them a framework for understanding the holes that there are presently that are so evident. So in comparison to other countries, we're at the bottom in amenable mortality. This is 32 causes of death where age and risk adjusted, where timely and effective intervention could have prevented death. We're last. In hospital admissions for preventable disease, specifically diabetes, asthma, heart failure, and hypertension, again, where treatment that is administered and adhered to could have prevented hospital admission, we're last. And for a lot of people, the most surprising, in medical, medication, and lab errors, we are last. we have fewer physicians than nearly all other countries, and we're facing a shortage of physicians of 59,000 to 133,000 between now and 2033. And we have fewer hospital beds. And we fund hospitals different than most other countries in the world. So in the spring of the pandemic, hospitals were furloughing and laying off staff while their emergency rooms were buried, largely due to funding hospitals through elective procedures. I will talk a little bit about the Organization for Economic and Community Development. That's Western Europe, Japan, South Korea, Australia, New Zealand, Canada, US, Mexico, and Chile. Out of those countries, only one other country does not have universal sick leave. Now, Washington State does. It's one of 13 states that does. But look at the number of people in service industries that don't have paid sick leave. That becomes more concerning because a study a few years ago found that 20% of healthcare or food service workers had gone to work sick with either vomiting or diarrhea in the year before. And of course, we started the pandemic with 30 million uninsured Americans. The number went down slightly with the Affordable Care Act, but it's gone up the last 3 or 4 years. And how many people exactly have lost insurance we don't have a good way to measure. Many have been forced into unaffordable plans. At least 3 million more have permanently lost insurance. For those that do have insurance, what has happened in the last 10 years is wages, as you see on the bottom line, have been virtually flat, medium wages, while the employee share of healthcare costs has risen 59% as more and more of the costs are shifted to employees through premiums, co-pays, and deductibles. But the one place we're number one is in healthcare costs, and they're not only higher, they're enormously higher than comparable countries. Switzerland is the next highest, and we're 41% higher than Switzerland. But the insurance companies have done very well with the pandemic. 5 largest, their profits are up 76% in the last year. Again, because of how we fund. We don't really have a healthcare system, we have a sickness industry. Of course, there's been a lot of focus on long-term care, and now things are going down and getting better in long-term facilities, but still 55% of the deaths in the state have been associated with long-term care facilities. And all countries have had some issue, but ours, again, is exacerbated with our lack of support for long-term care. The GAO did a study last year of 5 years worth of nursing home infection control inspections. In this state, only 14% of nursing homes had no issues. 56% had multiple years infections or deficits, and 40% had consecutive multi-year deficiencies, which shows a really serious issue. In compared to OECD countries, we spend a tiny fraction in government spending of what other countries do on long-term care. Just the other day, the Seattle Times had a headline, "We should have been better prepared. COVID-19 draws attention to Washington State's underfunded of public health programs." They estimated that we're underfunded by $255 million in the state. And we're not alone in that. Inadequate funding for public health is rampant. Local health departments have lost 55,000 workers nationwide since 2008. Public health is focused on well-being and health. The benefits are in the future of those that don't get sick. And we don't know up front who it is that's going to get those benefits. So there isn't a big constituency for public health. It's been easy to cut the budget to meet other needs. And there's no consistent coordination. We have about 2,800 locals, county, and state health departments across the country. Each runs its own way. In the pandemic, for example, each one decides how it's going to count COVID deaths and sick illnesses. Sorry. We'll go back here. Those local, so and which stats they just choose to track. Often local health departments have to fight each other to get basic resources, PPEs, for example, in this last year. And there's no national data system. Now, there's a big thing in the last year, the administration changing the data reporting from CDC to HHS. But the reality is neither one has a nationwide data system. Local departments transmit that data in emails, spreadsheets, all kinds of ways, and then it has to be re-entered into and there's no standard of what is reported. So if you want national data or even state data in terms of the disparate impact on people of color, it's spotty. In this state, 40% of that information isn't available. Some states don't report it at all. Of course, we've also faced another pandemic this year, or we've had to realize an ongoing pandemic of racism. Yesterday's Seattle Times, or today's Seattle Times, I believe it was, had a reporting on deaths in the state. It didn't show these figures. It showed age-adjusted figures, which make it look like there isn't such a disparity. But the older population of the state is very white. And if you adjust for age, you see the enormous disparity in who's dying in the state. And if you look at two factors for COVID, you see virtually the same disparities. And you can also, and of course, these both obesity and diabetes are related to a variety of social factors. But there's another factor that is influenced both of the diabetes and obesity, and that is the microaggressions that people of color face every day. There have been studies with various different ethnic groups of the impact of that day-to-day racism that physically changes our bodies and leads to more susceptibility to diabetes and obesity. Of course, they're the whole gamut of housing. Last spring, farm workers in Eastern Washington went on strike and marched to protest the lack of sanitation and water in the fields and the conditions, overcrowding conditions in the packing sheds and food processing, and the bunk housing that was provided. Some of those factors were addressed. But the reality is, if you look at a map of the counties with the highest COVID rates in the state, they track identically with the highest farm worker populations. People of color have less access to health insurance. And of course, that's especially true for immigrants. So we have a system drastically in needing change. And our experience should teach us, and we have to communicate these messages so people understand we can't go back to what we've had. First, that when millions do not have health insurance and paid sick leave, we're all more vulnerable. That's what we learned. It's not just those that don't have the insurance or sick leave, it's all of us that are put at risk. Employer-based health insurance breaks down when the economy collapses. And this happened in 2008, 2009, and of course, this happened even more in this last year. And we have to pay attention to our public health system and not see it as something that's the first place to get cut. And overcoming racial and ethnic disparities in healthcare involves addressing the social, economic, environmental, and political determinants of health, as well as access to more affordable healthcare. And we need a system that'll universal and affordable, that can allocate resources where they're needed, not just where the most profits can be made.
All right. Thank you, Steve. And thank you, League of Women Voters, Seattle King County, for this forum. Much appreciated. I've been asked to speak about how universal health care fits into all aspects of justice and equity goals. Let me just start with a few points that I imagine everybody will agree with. First, health care is a human right of all people. Second, all humans also have the right to optimal conditions for good health. Third, healthcare itself plays a fairly small role in shaping our health. And as Maureen said when she opened, much more important are the social determinants of health. And fourth, health justice really is inseparable from racial justice, economic justice, gender justice, immigrant justice, environmental justice, and the fight for universal and equitable healthcare is connected to all these other fights, as well as to the fight to defend and strengthen our democracy itself. Now, we know that single-payer healthcare, Medicare for all, even the public option idea, are fiercely opposed by the powerful medical industry and its political allies. They are hell-bent on protecting the wretched system, which is unique in the world, that puts healthcare profits above people. Our challenge is to build a broad intersectional movement so that our grassroots strength, together with that of our elected allies, can prevail over the profiteers. So, how would Medicare for All help us get to health justice? First, of course, Medicare for All will include everyone. Everyone in, no one out. What else? 3 points. Cost. We know that a single payer system with no cost sharing at the point of service will remove most financial barriers to healthcare access. Cost is the biggest barrier for the roughly 87 million uninsured and underinsured people in our country who are disproportionately people of color. 2, income redistribution. A single payer system will be financed largely by progressive taxes, with the effect of redistributing income and wealth down the ladder. The Affordable Care Act, something a lot of people don't appreciate, resulted in the largest income redistribution of any federal program in many years, especially in Medicaid expansion states. The ACA also reduced income disparities among racial groups. Medicare for All should have an even greater impact on income inequality. Third, addressing the social determinants of health. For starters, of course, a universal public plan will increase access and quality to the whole population, better distribute health resources to underserved communities and rural areas, and we can mandate with such a national plan implicit bias training for healthcare professionals and to track health data specific to racial and other important demographics, to the point Steve made, that we need a national database. We can have that. Beyond that, a huge benefit of the cost savings of a universal public plan is that it will free up resources to address the social determinants directly, which account for at least 80% of our health status. Last year, our Universal Healthcare Work Group found that a universal publicly funded and administered health plan would save between $5.6 billion and $9 billion every year once it's up and running. That's our state. At the national level, recent studies of Medicare for All proposals, and there have been a lot of them, and this in Congress, the studies in Congress, Congressional Budget Office, find that annual cost savings of over $400 billion. So that's a lot of money that could be invested in affordable housing, education, infrastructure, renewable energy, environmental cleanup, retirement security, and so forth, and more. all of which will improve the health of our people. I want to conclude by touching quickly on some key federal bills in play now and in the near future. The America Rescue Plan. This is the $1.9 trillion bill that President Biden considers a down payment on his campaign pledge to build back better. It includes, among many other things, it includes important gains for public health, for Medicaid expansion, and for health benefit plan, exchange plan affordability. It's a lot of stuff in it, some of which is not the best, but it's got so much important stuff in it that we should all be clamoring for its passage. Next, Medicare for All. This gold standard of progressive health policy will be reintroduced on March 17th at 9 a.m. our time by our Congresswoman Pramila Jayapal and Senator Sanders. Just got the word on the introduction day and time a little while ago. Watch for an announcement of that. It's a universal public plan that covers all necessary medical care with no premiums, no deductibles, no copays, and free choice of provider. It improves on traditional Medicare by covering vision, hearing, dental, and long-term care. Although on long-term care, the provisions are different in the House and Senate bills, and several other provisions are different as well. And so Medicare for All will eliminate private insurance for Medicare covered benefits. It will also preserve the ability of unions to negotiate multi-employer plans to provide other benefits not covered by Medicare, not just healthcare, anything, retirement, pension, education, what have you.
My timer said 1 minute, David, so.
Really?
Yeah, but
okay.
There's gonna be time for Q&A too, but.
Okay, so it's going to be financed by payroll and progressive taxes. The funding mechanism is not in the bills. The State-Based Universal Healthcare Act, I really want to hit on this. This is the second track of a national strategy that's emerged among advocates in the last few years. It'll be reintroduced a month after Medicare for All by Representative Ro Khanna of California. And while we need to keep fighting to increase support for Medicare for All, there are a number of states, it's not going to be enacted this year or next, most likely. But our state, Oregon, California, New York, Minnesota, and other states are politically very close to creating universal public health plans, thanks to years of grassroots organizing and advocacy. But states can't do it on their own. They need more control of their federal healthcare dollars and more regulatory authority. The state-based bill would provide this very support to states or groups of states. It's a perfect match for our efforts in Washington to achieve a universal public plan, which you'll hear more about shortly. And we think that this is only Jayapal and Smith in Washington have been on this bill in the past, and there will be a Senate companion this time. And we must persuade others in our delegation to support this bill as a step that they can take toward universal health care this year. Healthcare Emergency Guarantee Act, I guess I don't have time, important, it may not come up again, but Pramila has outlined several what she calls foundational elements of Medicare for All that she thinks Congress could take action on this year on the road to Medicare for All, including lowering Medicare age to 50, covering all kids to 25, automatically enrolling unemployed people, and negotiating lower drug prices. Last comment, after working in healthcare myself for 45 years, I retired in 2015, and I've maintained my activism for health justice, activism, and now I have renewed hope that we're going to get there in our lifetime. Our time is coming, so everyone in, no one out. Thank you.
Very good. Yay. Thank you so much, David. So, and sorry for the rushed schedule. We really have it packed in tonight, but we have 5 minutes of Q&A now, and Kelly's been collecting questions, I think.
Yes, so I have a couple. David, could you repeat the date and time that the Medicare for All bill will be reintroduced? Because I'm not sure I got that right.
David, you have to unmute.
Unmute, David.
Wednesday, March 17, 9 a.m. Pacific time.
Great, thank you.
And that will be Pramila and Sanders jointly introducing both of their bills.
Oh, how exciting.
Quite an event. I'm sure it'll be quite an event.
That's really great. And you both talked about things that we need to address with our various electeds. Could you, if I was to leave this meeting tonight, could you tell me 2 things high impact that I could do to move this effort forward?
Well, first, I would say get a hold of Senator Murray and Cantwell and make sure that they're going to get the American Rescue Act through the Senate.
Mm-hmm.
Second, I think it's a good time to communicate with your representative and both senators that we really need urgently universal health care, affordable health care, equitable health care. That's why we're for Medicare for All. We want them to, and we want them to get behind the state-based Universal Health Care Act when that's reintroduced in April, so that our state can get the help it needs to get to universal.
I would add absolutely to all that. The other thing is we need to build a broader movement. There are a whole lot of people that know that things are not really good, but they're comfortable with their own health care. And we need to get them to see that this is an issue for all of us, and we absolutely have to change. So it's telling stories to get people to really get committed.
Well, Steve, you have a
Make more difference in the
fantastic presentation that we should definitely get on the road. I think it's really helpful. That's all I have.
Oh, great, because we're running over time. I'm so sorry. But I wish we could hear more. All right, thank you so much. And our next presenters are replaced. No, let's see, who's the next presenter? I've got, yes, replacing Jen Nye from Whole Washington. We have Sean Kavanaugh, Andre Stackhouse, and Sarah Moe. Sean's a volunteer campaign director for Whole Washington. Andre's a volunteer as well, and Sarah Moe is a volunteer coordinator. So we would like them to start their presentation. Thank you
so much. Thanks for having us. My name is Sarah Moe, and I'm a volunteer with Whole Washington. We're a grassroots organization. I volunteer with Whole Washington because this time last year, I lost my job as a result of COVID. And as a result, I also lost my insurance. 3 months ago, I started having pain in my breasts. I delayed seeking treatment for fear of the cost, but I eventually did have a mammogram and an ultrasound, and they revealed what we all dread: 3 masses that needed to be biopsied ASAP. My biopsies came back clear for cancer, but positive for PASH, which means I'm not out of the woods yet. I'll require mammograms and biopsies about every 6 months for years. The fear of cancer should not be compounded by the fear of going bankrupt. The added stress and burden of scheduling necessary treatment at facilities that take our insurance should not be added to the already immensely stressful situation of needing treatment in the first place. This is why Whole Washington exists. So to talk more about what Whole Washington does, I'm going to pass the mic off to Sean Kavanaugh.
Thanks, Sarah. Whole Washington is a grassroots organization founded on the idea that healthcare is a human right. And our goal is to win universal healthcare for Washington State and start a movement that will eventually lead to a national Medicare for all. We've been active since 2017, and we've really been getting going. In 2017, before we wrote our bill, we funded an economic study with one of the leading world's healthcare economists, Dr. Gerald Friedman, to take a look at Washington State and how much we would save. And we would save billions, like David pointed out. So we took that data with that doctor and with other organizations, wrote a universal healthcare plan that would provide more coverage, cover everybody for less cost. And we ran with a ballot initiative in 2018. Now, we didn't get all the necessary signatures, but we were undeterred and went back in 2019 to reintroduce our initiative as a bill in the Senate. We got 3 co-sponsors then, and then coming back in 2021, We've doubled our co-sponsors in the Senate, with leading prime sponsor Bob Hasagawa with 7 co-sponsors. It hasn't passed the out of committee yet, but we're confident that we can get it and not go on to another ballot initiative to win universal health care. Now, why does Washington State need universal health care? Well, we need it because our private employer-provided health care leaves women vulnerable, and especially in this pandemic, it has exposed the weaknesses that our system has. Now, for most of us, our healthcare is tied to our jobs. But during the pandemic, millions of people lost their jobs, and it especially hit hard for women, who have lost 1 million more jobs than men. This leaves women like Sarah vulnerable to getting sick and figuring out how to pay for these costs. This leaves women dependent on their spouse or their job, putting them maybe in situations that are unsafe because they need that healthcare for themselves or their kids. And it leaves working class women behind. Even though we pay the most for our healthcare in the country, it provides almost no benefit for life expectancy compared to men. Only the most affluent women have gained life expectancy over the last couple of years, but the bottom 40% of women, predominantly people of color, have actually lost life expectancy. That should not be the case. And also for Washington State, more and more of our healthcare costs, since it's going up each year by about 6%, is eating away at the paychecks of workers. In 1998, 18% of employee compensation went to providing for healthcare. And now in 2014 and today, it's about 27%, with projections looking in the next decade to eat up a third. Now, what does that mean? That means less money for food, for medicine, turning people from homeowners to renters. And for women, it just represents another way that wages have been taken away from them, where it could have been going to equalize the gender pay gap. And so now we're going to go to Andre, who's going to talk a little bit more details about our amazing bill, SB 5204.
Hey, everybody. So I'm Andre. I'm also a volunteer with Whole Washington. And as part of our goal to pass this, especially via ballot initiative, we have to do a lot of work to make sure people understand how our bill works. And the best way to do that is to make it simple. So I try to emphasize 4 points. And that is that the Whole Washington Health Trust is public health insurance that is, 1, universal. That means not just all residents are covered, but also all doctors and all hospitals are in the same network. So we really want to emphasize that it will take that particular limitation and give us free choice of where we want to get care. The next is that it's comprehensive. Anything that you need is covered. So we're talking about regular inpatient and outpatient care, routine preventative care. We're talking dental, we're talking vision, mental health, reproductive care, more comprehensive care than pretty much any, than the current Medicare and Medicaid plans, more comprehensive than most people's private insurance right now. The third is that it's nonprofit. We're not going to skim extra money off the top. We don't need to pay out to shareholders or CEO bonuses, advertising. We want healthcare to cost what it costs and no more. So that's why it's nonprofit. And the last is that it's free to use at the point of use. No surprise billing, no copays, no deductibles. Nobody hands you a bill on your way out. You don't have to call your insurance company. You get the care that you need because you need it. It's a good deal for businesses as well. Pretty much all businesses, either their top or one of their top costs is going to be the cost of providing healthcare coverage to their workforce. This is especially true of small businesses. So all of that money that is spent on shopping for healthcare plans, administering them, and managing them, That's personnel, that's time, it's money that the business could be investing into their own wages and their products and services. And it also traps their workforce who has their health insurance tied to their employer. So it frees up workers to change their jobs or start their own businesses as well. So people usually want to know how much it costs. And we've already mentioned that we had Dr. Gerald Freeman, economics professor at University of Massachusetts Amherst, analyze our plan. And his analysis finds that we would save over 9 billion a year. And we really like to emphasize that it's not only that it's cheaper, but that it is providing universal coverage and eliminating medical bankruptcies. And we would be happy to go over in more detail how any of this works at a future meeting, if that's something that people are interested in, because we're trying to keep it very high level at the moment. But go ahead, next slide. Right, so
Andre, 1 minute.
great. So how do we pay for it? Big picture, the answer is progressive taxation. Right now, people are scrambling together GoFundMes for their healthcare coverage. We think that's ridiculous. The money definitely is here. The answer for how we get it is progressive taxation. And this is a general outline of how it works. Most of these have exemptions, especially for our people at lower incomes. But yeah. You're muted, Sean.
So the status of our bill that it hasn't passed the healthcare committee, there's many reasons for this, but to reassure everybody, this is a universal healthcare bill vetted by state agencies who are responsible for collecting the funds and backed by a study with the input of healthcare professionals, consumers, and legislative experts. And we plan on continuing to fight this in the Senate and ballot initiative.
Thank you. Can we move to the Q&A for you guys now?
Yeah.
Thank you. Thank you so much. I know this is squashed.
No
That was a lovely presentation. So Kelly's been monitoring the questions again.
Yes, and we had a little mix up with the chat, and it's on. So pour on your questions. I did get one question from Glinda, and she asks, are employers working with us to get any of these bills passed? Wouldn't it be in their interest to not have to provide health insurance to their employees?
Yes, we have several business leaders and bosses that want to get universal health care. Some of them don't have the resources to provide for their employees, and by language in our bill, we would have exemptions for small businesses that couldn't. And then also some business owners pay about 20 to 30% for their healthcare costs. And under our bill, they would only pay at a maximum 10.5% if they also included covering their employees' payroll tax contribution.
Thank you. So that right now is the only question I've received so far. Oh, wait a minute. One more might have just come in. What was the advantage money of his 4 points? Sasha asks. Not sure I totally understand that question, but.
So maybe you could use your Q&A time if you have some point you want to emphasize. You have a little bit more time.
Yeah, well, what we really want to encourage people to do is join the coalition, right? Because I think we've now seen that this is super beneficial. So if you want more information on Whole Washington, or you want to join our coalition, you can do so by going to wholewashington.org. You can also find us on social media at Whole Washington. And please contact your representatives. Let them know that you support SB 5204. That's our bill. Sean probably has more also.
What do you guys want to know? I mean, like, we've gone to the Department of Revenue and Department of Employment Security and make sure that our funding mechanisms are legit. They gave us multiple options to funded, and this is the way that we came up with. And yeah, we fund it progressively with a capital gains tax of 8.5%. As everybody knows, Washington State is the most regressive tax system in the country, meaning that poor people pay more of a percentage of their income in taxes, while Jeff Bezos does not. So that 8.5% tax on capital gains, which does not target anybody's retirement or farm income or things like that. And we put that in there to address that.
Well, thank you, Sean. You know, if people have questions for the whole Washington crew, you can put them in the chat and we'll collect them up, because maybe there'll be a little bit more time in some of the other Q&As too. Okay.
All right.
So I've got my husband sitting right next to me being the timer. So otherwise this would be all over the place. So thank you for your patience, and thank you so much for your presentation. So now we're going to move to the next item on the agenda, which is Bevan McLeod, co-founder and president of the Alliance for a Healthy Washington. And Bevan is the only person on our panel tonight who was also part of the legislative work group. So I'm hoping that we get a little idea of what that work group did and accomplished. Many of the people on the panel worked very closely with the work group, but Bevan was actually on it. So are you there, Bevan?
I am. Can everybody hear me?
Mm-hmm.
Okay, great.
Yeah.
And I'm sharing my screen. I hope that the audience can see it. So I am going to try and be very brief because I'm kind of covering a lot of ground, which is to take a look at what we've done through the legislature in Washington State in the past, kind of present, and then looking at the future. So just want to talk about the past super quickly. Just in case folks aren't aware, so the Basic Health Plan, which was established in 1987, was actually passed after an immense amount of commission work, and was signed into law by Booth Gardner, and then finally ended in 2014. Long-standing program that people throughout Washington State really loved. Cover All Kids, I will say, 2007, after about a 25-year battle to cover all kids, in 2007, RCW language was finally enacted that established an intent by the legislature to cover all kids. And in 2010, that was, oh, I don't know, I guess I wasn't sharing the screen. Oh, there we go. In 2010, the legislature actually enacted the Cover All Kids. I'm getting help from my buddy here. And then I wanted to talk a bit briefly about the Healthcare 2000 initiative to the Washington State Legislature in 2000, which was both to the legislature and to the people. There are folks at Healthcare for All Washington who I'm sure have lots and lots to talk about in terms of you know, their experience with that. Unfortunately, that didn't get onto the ballot. And so it was submitted as a bill to the legislature and has been sitting in the legislature for over a decade, and finally got a hearing in 2017. That was a post-cutoff hearing, which meant that it couldn't get out of committee, but at least Representative Cody gave it a hearing. So ever since 2017, I have been working kind of at the legislative level to work on how do we kind of pull the pieces apart of getting to a single payer healthcare system in Washington State that we can pass progressively each year. So I just wanted to give a little bit of background too. In 2019 to 2020, we passed Drug Cost Transparency Bill HB 1224, which passed with bipartisan support. And I just want to put a couple of these forward because I think as we talk about a universal healthcare system and the savings that Washington articulated and David articulated, you know, part of what we need to tackle is the total cost of care. And part of that, of course, is the cost of drugs. So our prescription drugs specifically. So our legislature saw that and put into RCW this requirement for the transparency of costs. And as you can see, it really requires and demands quite a bit from not just the manufacturers, but the pharmacy benefit managers, et cetera. Also, what was passed in 2019 was the Pathway to Universal Healthcare Work Group, which we helped to write and then get passed. Kelly Powers and I both served on that work group over a year. We committed our time to that work group and really dug in. Of course, I think we didn't make as much progress as we wanted, as work groups tend to do, but there was a lot of effort and a lot of dialogue. It was a bipartisan work group. The Healthcare Authority has the register on there, and you can see who served on that work group. So what came out of that work group was an actuarial analysis done that, as David articulated, even at year one, even with implementation costs, would save the state $2.5 billion and then upwards to $5+ annually, which is really significant. And of course, you know, as our Whole Washington presenters pointed out, Gerald Freeman also has that report that shows even greater savings. So there's no question that a single payer system is going to save our entire state billions and billions of dollars that we can invest in other ways that are also crucial to our state and the health of our state. So coming out of the work group, we, you know, Kelly and I could give you all kinds of background on this, but we pushed really hard with the actuaries, with the folks who were administering the work group to really push and get as much information as we could in the time that we were allocated. And so what came out was a final report, which is also on the Healthcare Authority's website, and it's available to the public. I've also put links in this presentation, which I've shared with Mo, and anyone who's interested is welcome to take a look. But the final report really talks about the first step in the transition process being intent language into RCW that commits our state to achieving universal healthcare by a date certain. And we saw that happened with the Cover All Kids. So and from there, defining the coverage, financing and program standards, developing and financing a plan, et cetera. You all can read. So I want to make sure there's time for Q&A as well. So the legislature, 2021, here we are. We all know that we've gone through an astounding year, a historical year that humanity probably won't see again for a very long time. So as our state legislature grapples with the total burden to our state, we also know that we have to make progress in achieving universal healthcare. And so coming into this legislative session, really tried to think about what could we do that's achievable right now? And taking the history from the Cover All Kids, decided, hey, look, we should get this intent language in place and make sure that it's put into RCW. We should also establish a Universal Healthcare Commission to make sure that we get all of the nuts and bolts in place by a date certain, so that the legislature not only is forced to do it because it's an RCW, but they also have the blueprint to get it done. So also this legislative session is the SB 5377, which is what people call Cascade Care 2.0. And I'm going to get back to that because there's a really key piece of that legislation that we're really tuned into that matters big time in terms of achieving a universal healthcare system with single payer financing. There's also the Health System Transparency Bill, which is put forward by Representative Macri, that again looks to tackle the total cost of care in the state. And of course, as has been mentioned, progressive revenue, because if we're going to be able to fund this, we have to have revenue streams to pull from. So the Universal Healthcare Commission, date certain and commission, the intent language, you know, it's a bill that everyone can read. It's legible, and I urge everyone to do so. But in the first part, it's very clear that we are to get to a universal healthcare system by 2026. The second part establishes that commission, and it's again very lengthy, but you can see that there are very specific areas that pull from the Universal Healthcare Work Group, and what the final report was saying, hey, listen, this is what we got to do. So I will say that we're going to have to continue to push. And I also will say that if anybody has any edits or amendments that they think should be added. We're headed out of the Senate and into the House. And so if you have some thoughts to offer, please send them our way and we'd be happy to put them forward. So really briefly, one of the reasons that we're really looking at 5377 is for the section on the healthcare affordability account that is created in the state treasury. And right now we're working on getting some amended language in there that would expand the ability to utilize the revenue that are put into that state account. And as we start to apply for federal waivers, as we hope that the state-based universal healthcare act at the federal level is enacted and the state is able to bring in those federal funds into that account, we can start to use those funds to expand state-based programs on affordability and accessibility, and ultimately to finance a single payer system by 2026. So that in and of itself is also incredibly key. And then just wanted to highlight the health system's transparency, which again, if you think about it, the components, right? We have to tackle the cost of drugs, prescription drugs. We have to tackle the cost of the system itself. So Representative Macri has drafted a really pretty phenomenal piece of legislation that, knock on wood, will pass. And it's making good progress that would require all of the hospital systems in our state to offer transparency on their financing systems. So that's another really key piece of policy that is being put through the legislature right now that ultimately will support a total universal healthcare system and a single payer financing system. So kind of our last slide here is just to say that we're headed to our destination, which is a single payer system by 2026, and to have that in place. I will say that, you know, folks have said, hey, why don't we change the due dates in the commission bill in 5399 to say that the first report is due in 2023 and that we have a single payer system by 2025. I think that's great, and we've put that forward, and we're going to see, you know, what we can get through. So keeping complex intergovernmental agency and stakeholder work accountable and arriving on time. So, you know, assuming that this bill does pass, it's going to take all of us making sure that we hold the legislature accountable, that we hold the commission members accountable, and that we actually continue to get these components done. And just kind of looking forward, I would say, you know, look, if there's any piece of, you know, a single payer system and getting there that we can put forward next year, and then the next year, and the next year, let's do it, right? We have to, I think, unfortunately, not everybody is ready to move as fast as we want them to. And, you know, but we have to continue to put pressure on them and make sure that they're hearing the voices of the community and asking them to make significant changes. So I'll just end by saying, you know, this is the strategy of Alliance for a Healthy Washington. I, you know, worked with Healthcare for All Washington in 2017 and lobbied on the Washington Health Security Trust bill. And just from my personal experience in Olympia, felt like, hey, you know, if we can break this down into bite-sized chunks over the next few years, I think we can get this done. So that's how we're working. We have a robust legislative agenda that includes lots of other bills that I hope help move us forward on this trajectory. So I'm going to leave it at that. If folks want to get in touch with me or the organization, take a look at the link, and I'll just open it up for Q&A, because I think that that is often how we learn the most from each other.
Thank you so much, Bev. So Q&A at this point, and if we missed any other questions before, maybe we can wrap those into the end of the Q&A.
Great.
And thank you. That
So
shows a lot of work.
I have one question that I actually want to direct to David Loud. And there's a lot of questions about, wait a minute, this is still getting a little overwhelming. There's so many pieces. How does it all fit together? So David, I'm wondering if you could speak to that. You know, how does the Washington Health Security Trust fit in with the commission? fit in with all of the little bills that are moving forward along the way. I'm definitely putting you in the hot seat there. Can you, you might be muted, David.
David, you're
Yes,
muted.
yes. I don't know if I have good answers, and I welcome others' comments as well.
Yes, for sure.
But there's the question you posed sort of at the state level of how the different efforts going on fit together. I will just add that it gets more complex because it also has to deal with the federal level and what we can get the folks in DC to do to help us here. And I think what it's going to take really is over the next several months for all of the constituencies and organizations that really want to see this happen to put their heads together and think about how we can, what we can do, particularly in 2022, in the next legislative session, presuming that there's going to be a commission, what we can do to sort of guide that commission in the right direction. The bill to create the commission, as I understand it, offers them essentially two options, which came out of the Universal Healthcare Work Group. A universal publicly funded plan administered by the state, which is really the single payer plan. And the second possibility that came out of the work group is a universal publicly funded plan, which the state would then contract out to other people, to insurance companies, much the way managed Medicaid, has evolved over the years. And I think that's something that we're going to have to push back very, very hard against, because the goal here is to get the insurance middlemen out of the picture so that we get the savings of a true single payer plan. That's going to be tough because, you know, if we thought that the climate initiative 1631 in 2018, which was, you know, well-funded, well-organized, had a broad coalition, but $26 million from fossil fuel went and crushed it. Well, we have to anticipate that the medical industry is going to come at whatever we put forward with an even stronger opposition. So, like I say, I think the most important thing is figuring out how broad a coalition we can put together to get behind what we want the commission to implement.
And I'd like to chime in here too and say that from my viewpoint, having been on the Universal Healthcare Work Group, I think there's three key things. One thing that came out of the Universal Healthcare Work Group was a timeline of implementation. And when you look at it, you realize, wow, this could really happen. It's possible, but it's not going to be that hard. And then we have the Washington Health Security Trust, which has further details about how it could happen. And we have the work of setting up the actual commission itself, this legislative session that we're trying to move forward. So to me, yes, there's a lot of desperate parts, but they're all moving toward the same direction, and we need them all, and we're going to keep moving forward.
I would maybe just like to add that, you know, one of the things that distinguishes, well, I don't know about distinguishes, but I think it's important to remember that we have the ballot initiative as well.
It's the Q&A that ends it. Excuse me. Sorry.
Oh, sorry. Just that we have the option of the ballot initiative as well. And so it's been an important part of whole Washington's strategy to sort of combine a legislative strategy with a ballot initiative strategy, because, you know, we do believe that the fastest implementation would be through the legislature. And that's why we've worked with that strategy and we have a bill in the legislature. But in order to kind of keep a continuous campaign forward, should it not pass in the legislature, by having the ballot initiative, we're ready to immediately roll that organizational work, that legislative work, that coalition building work into a ballot initiative campaign. So I think it's important that we remember all of the sort of ways that we can pass this.
We need a lot of pressure points for sure.
So Kelly, were there any questions for Bevan, or Bevan, did you have any?
One minute.
We have about a
There's
minute on
question
this
about
Q&A.
labor. There's not, I didn't see anything for Bevan specifically. There was a, Duffy had a question from earlier about, I think maybe I did address that one. That was more about the,
Okay.
I'll say, just to chime in super quick to Pam Dolan's question about labor and what they're saying around 5399. So I will just say that you know, we've gotten the support of WEA, the Washington State Labor Councils, the Teamsters Joint Council, 1199, excuse me, SEIU 1199 Northwest, SEIU 775. And multiple other smaller unions, and have had testimony in several of those hearings. So obviously labor is very much on board with 5399, and I know that most unions at this point are very much supportive of single payer and universal healthcare. So I think that probably goes for both.
Mhm.
Right. It's a complicated issue, many hands on deck and many more needed, it sounds like, but the work is progressing. And this sounds to me like the most activity I've heard of in ages. So thanks to all the efforts. And apologies, Kelly, that I didn't, when I said there was only one person here on the work group. There's two. So
No
very
worries.
good. So well, now that this Q&A has ended, we're coming to a part of the program where we have 3 League of Women Voters members from other counties in the state who have agreed to come. And other counties are doing much more work than Seattle King County on healthcare in League these days. Much more that can be any, because Seattle King County hasn't had a healthcare committee or action group for a long time, I understand. I haven't really discussed with our guests how they're going to set this up, so I'll turn it over to them. We're welcoming, let me get your names right, Nancy Field, who is a retired hospital administrator, board member, and healthcare committee chair with the Clallam County League of Women Voters. Jody Disney, who's a PhD, RN, and CNM retired and member of the Thurston County League of Women Voters. And Sherry Lambert, who's here as a member of the League of Women Voters from Bellingham and Whatcom County. So it's been a pleasure to meet all of you via email and now on Zoom. So have you decided how you'd like to proceed? Does one of you want to take the stage first?
Mo, I think you asked me to go ahead, so I'll.
Oh, great. Okay, thank you.
Jump in there with I'll share my screen and get going here. I'm Nancy Field. I'm a chair of the healthcare committee here in Clallam County. Clallam is out on the Olympic Peninsula and includes all the way out to Forks, Port Angeles, and Sequim. We're a small community, a large retired community, and that I think gives our league a little bit more resource than a lot of the counties where a large number of the league members may be more employed and have multiple other obligations. But I wanted to just say a little bit about what we do, and it's really going to be sort of from the ground up. You've been hearing a lot of information that's national and statewide, and this is really at the micro level. Our committee has a central objective, and that is that access to healthcare should be available and local. And we think of access as both financial access, which we've been hearing about tonight, but also that services be available locally. We're a rural, low population area, And over half of the hospital beds in Washington now are controlled by religious organizations. And most of the hospital districts also have fairly conservative approach to the services they're willing to offer. And we're learning to perhaps maybe be a little more vocal about the separation of church and state than the league is comfortable with talking about using the word religion, but we're starting to have to do that. The Virginia Mason merger into Common Spirit, which is a merger last year of Dignity Health and Franciscan CHI, has really triggered an awful lot of concern statewide. And it's led to our some further thinking on our part about what we might do both locally and statewide. And that's partly informed by the fact that we have 2 public hospital districts that serve the population in Clallam County. And so this first slide simply just says this is kind of what we're about. Historically, healthcare concerns at the league, which has been around for a long time in Clallam County, has addressed some key issues that happened here. In 2006, Virginia Mason had a very large presence here, and it left. And there was a lot of work done at the community level that resulted in the tribe, the Jamestown's Clallam tribe and the hospital taking on the physicians who were left without a base when Virginia Mason left fairly precipitously. The league got very involved when the Washington Death with Dignity law passed, held forums, and created more transparency for the hospital's decision not to participate in that law. About 2007, Providence and Olympic Medical Center struck an agreement whereby the hospital would use its information system, and the league again provided for some transparency about what that could mean for services at a public hospital and making sure that it didn't affect the service offerings here in Clallam County. We write letters of support either from the board or from our committee when issues come up, for example, the site neutral budget cuts that some of you may be familiar with. And recently, when a commissioner resigned from the board, we suggested criteria by which somebody should a replacement. So there's also a lot of ongoing activities that relate to the fact that the league, because it takes public positions on public policy, can't do this when your hospitals are private. But we're beginning to appreciate the power that the league can have and also empower its citizens when your district hospitals are owned by the public and they're obligated to respond to public needs and requests. So I'm not going to go through all this list here, but there are an awful lot of things by which we involve ourselves regularly with the business of the hospital. The strategic planning, the commission elections are a standard part of our voter services activities. We've looked at this Honoring Choices program that the Hospital Association has imported from the Midwest. It doesn't reflect anything about death with dignity. And the Hospital Association, now that its members are more than half religious, we're very concerned about the association itself and its biases. And they're so far unwilling to include death with dignity in their Honoring Choices program. So we're seeing the private side of healthcare not working as well as the potential for the more public side of healthcare in terms of our providers. And one of the things we'd like to do, which we're already doing for the PUD and hospital, for the PUD, for the county commissioners and the city council of Sequim, is to reestablish monitoring of the board meetings. We had a voter services forum last year And we had some of our committee members, as members of the audience, ask a question of a commissioner candidate we were very excited about. But when we asked the panel of all the candidates what their view was on reproductive rights, the one we were most enthusiastic about said abortion is not healthcare. So that was pretty informative to us as to the kind of attention we need to really bring to the selection and election of the hospital commissioners that control the healthcare that's available to us in our rural community. One of the projects we're doing to expand that kind of awareness into other parts of the state, we're calling it a civics education project for making democracy work, which is the national theme this year. And we're looking at this map of all the hospital districts in the state. And there are two significant things about this map. One is that there's some holes in it. There are counties with very large populations and single religious-owned hospitals in those counties with monopolies, and there's no hospital district that's ever been created in some of those counties. 3 of those are Whatcom, Kitsap, and Cowlitz, with populations over 200,000. On the other hand, huge swaths of the state are covered by districts, and we think that very few people realize the potential power they have to influence the decisions about healthcare and what's available to them locally, that should not be restricted by religious considerations, including the fact that the state law requires that any public hospital district that provides maternity care is required by law to also provide abortion services. Now, the Hospital Association and some of the providers believe if they have a policy that permits abortion, but they just don't happen to have any providers who will offer it, that they're meeting the law. A judge in Bellingham disagreed with that, and it's still an open question as far as a lot of these hospital boards and administrators around the state. And our project, we think, will start answering more questions, or answering some of the questions of how much compliance with that law is actually taking place in this state. The ACLU has been involved in triggering that question in 2 or 3 counties, and we see them as a partner in this. So we're combining the idea of civics education with the fact that adult education really has to focus on things people care about. So we're going to help, if we can, put material curriculum together that is available statewide to all the leagues, where we talk about these districts, how they're formed, what the law says, and then also talk about some of the restrictions on services that we can actually learn a fair amount about, because through the legislature, we've got more and more requirements of hospitals to publish their actual services that they're refusing. And we're going to use some of that. These are the this is the form that's used for reproductive health services that every hospital must complete. This is a template for one on death with dignity and end of life. It's not in place yet, but it was put together, I believe, by the ACLU and Planned Parenthood and some others a couple of years ago. So we want to push for more transparency. But our goal in this project that we're taking to the state annual meeting in June is to make the statewide project of education. And we want this education about hospital districts and that law to result in people getting to know their local commissioners, their local administrators, and finding out whether those organizations can be more responsive to the local community and the services provided. Mental health in particular is a service that Washington is woefully inadequate in. I was involved in a behavioral health hospital project 3 or 4 years ago and was dismayed to see that Washington was second from the bottom in the availability of inpatient psych beds. You may be familiar with the civil rights decision in Tacoma that said it's not acceptable to be housing these patients in the hallways, that the state needs to put together a plan to increase the number of beds. There have been some issues with how that's been implemented, but we are here in Clallam County, one of 3 counties on the Olympic and Kitsap Peninsula with a population reaching 400,000 with 0 inpatient psychiatric beds. And that's the basis for another project that we're going to be undertaking later this year. So these are just a little flavor of the kinds of things that we're excited about. And this is one of the elements from our work plan. We want to, I've got a great group of volunteers. I think some of them are on the Zoom tonight. This is our initial team, and we're going to be working to develop a curriculum that helps people understand their districts, helps them interact with data and information about their districts so that we can go from education to citizen engagement and start supporting league members and league healthcare committees in improving the healthcare in their own communities. And this is just a little diagram of some of the media that we're going to consider using. That's all out yet still for our decision. And we're going to be taking this one to, as I mentioned, the annual meeting for approval as a statewide project. So we're looking for folks from other counties, either who have districts or need districts, that may be interested in pulling this together for the use of everybody in the state. I'd be happy to answer questions, but I think maybe we should probably hear from Sherry and Jody.
Yeah, thank you, Nancy.
Yeah.
What a great presentation, and what awesome work you're doing out in Clallam County. It's very impressive. It just makes me even more energized about King County ought to step up to the plate, right? So we can have some activity going. So yeah, I'm sorry, but you know, it's pushing so near the end, but Jody and Sherry, did you want to speak up? Thank you again, Nancy.
I just want to say quickly, thanks to you, Mo, for bringing this all together, and everyone else for speaking. But I was able, with a really nice advocacy team in Thurston, just to begin to bring healthcare into the conversation. And luckily, through the Zoom process, I occasionally get a breakout session. So that's really, you know, my background is all about serving underserved people and communities. So universal healthcare is near and dear to my heart, and this is my cat.
Well, thank you, Jody. And of course, Kim is in your county as well, right? Your sister counties, or sisters in the same county. And so, well, and so what about you, Sherry? Would you like to chime in too?
Sure, I'll go ahead. Can you hear me okay? I have to go down to my husband's desk because it didn't work upstairs. So my name's Sherry Lambert, and I retired from X-ray. I was an X-ray tech about 8 years ago. And I thought healthcare was pretty good then, but I realize it's pretty poor. I am the chair of the healthcare committee in Bellingham, Whatcom County, and Whatcom County goes from South Bellingham all the way up to the Canadian border. And yes, we have over 200,000 people here, and we only have one hospital, which is Catholic, Peace Health, and we have been actually talking to them about talking to the hospital districts about what it entails to have a hospital district up here. So anyway, you asked me to tell you a little bit about how our committee got started and what we've been doing. So we started in 2013 after a program that we had that was called Improving Healthcare. Can the ACA deliver? Well, after that meeting, we just decided we needed to get together in a smaller group and have meetings so that we could delve a little bit deeper into all the confusing issues of healthcare. And we meet, there's 25 people on our committee, about a dozen of us meet monthly. Most of us have worked in some capacity in the healthcare field. And we've had speakers from all areas of healthcare to answer our questions. It's been really interesting. And The goal of our group is to identify areas of healthcare that the League can have an impact on, and to identify an aspect of healthcare that members would want to develop into future programs for our members. So after our first meeting, our first program on improving healthcare, Can the ACA Deliver? In 2014, we presented issues and impacts of mental illness in Whatcom County. And it was obvious there's a real dearth of professionals available to take care of behavioral health patients. But at this time, our county was developing a drug court and also a mental health court, which we were following quite closely. And because we just believe that there's a better place for people than putting them in jail when they need this kind of help. So in 2016, there was a disagreement in our community about a new jail proposal that many disapproved of. And we wanted more care for patients that are addicted and mentally unstable. So we had another program for League members and the public on the pros and cons of the jail versus treatment. So the new jail has now been voted down 3 times. And we do have some 32, 34 beds, treatment centers have gone in, and drug court and mental health court is very successful. So that's really good for Whatcom County. Our committee has 3 subcommittees: universal care, end-of-life care, and behavioral health care. People leading the universal health care have been working on this for over 15 years, and we're all committed to the battle of getting single payer, preferably at the national level, but if need be at the state level. We signature gathered for 1,600, and we got more signatures than anywhere else in the state. So we were very proud of that.
All right.
County, yeah. So one of our members has been leading the charge to get everybody over the age of 18 to have advanced directives, because just too many families are torn apart and destroyed with disputes after somebody becomes incapacitated. And this would save so much grief for family members. She's actually become a notary because she wanted to notarize people's documents, their planning documents, and she arranges forums to educate the public about the importance of making your wishes known. And somebody was talking about not making your wishes known. You had another comment for it, but it was exactly, it just dovetailed exactly into what that committee is doing.
So I was supposed to tell you at 1 minute, but it's actually almost the end of.
Oh no!
So, yeah.
Well, 2 more programs, and
I just love hearing all the things you're doing. It's
preventive
awesome.
care right now is really. We realize the public health department has really been decimated over the years, and we're really pushing to get it improved. But we also our behavioral health committee put together a really good program, Be Mindful of Minds, and that was about mental health in our community and addiction again. And we had people from NAMI and the Opportunity Council, law enforcement, psychologists, and homeless outreach team, because we're interested in coordinating care for these patients, get wraparound care, keep them out of the emergency room, and keep them healthy.
Wonderful, wonderful. So many ideas.
There's so many, yeah.
Worked
So
on,
many,
and and it's a. In addition to that big question of universal healthcare, which has to, we have to keep working on that. There's all these other aspects of healthcare. So there are just a couple of more minutes left. If anybody needs to leave, go ahead. And I'm not sure if we get cut off right at 8:30 or what happens, but this was supposed to be the Q&A for the League women visitors. So did we have any questions, Kelly, that we can urgently ask before the time runs out?
No, not for this panel.
Everybody was just blown away by how much you're doing.
Actually, I did have one myself, which was you got my brain thinking about these hospital districts and wondering, is there anything we can do to advance universal health care within the hospital districts? Or I don't know if there's any potential connection there. Or
we do have we have talked with our local hospital administrator about the issue of Medicare for all, because that shorthand creates some real concerns. The rural hospitals in particular have what's called a payer mix, which is almost extremely high percentage, I should say, of Medicare and Medicaid. And if all patients were paying those rates, our hospitals would close.
Right.
So we are very foot dragging about about single payer until we see money on the table. We cannot afford to go to single payer without better reimbursement, or it would be the end.
Do you want to address that? I believe that there's a higher compensation rate in Jayapal's bill.
So
Yes, Steve.
it's a different mechanism for reimbursing hospitals. That's a whole subject of its own. And I'm sorry that Olympic doesn't seem to understand that they would actually do better, not worse.
Well, I'm not representing what Olympic is saying. I'm speaking for myself as a hospital administrator. I'm just saying we don't support it until we know that there's money that that the hospitals can live on, because the rural hospitals are so vulnerable.
So let me explain. Right now, hospitals are reimbursed on a fee-for-service basis, and they get their money for elective procedures. The more procedures, the faster. Get people in, give them the procedure, get them out of there. There's a different way of budgeting that most other countries use, not all, called global budgeting, where hospitals have a budget for the year. It's based on the population they serve and the needs of that population. And there are factors, one of those factors being rural hospitals that have greater expenses for serving. And so that is factored in to the formula, and that is a provision. Actually, I don't know Bernie Sanders' bill, he didn't have this provision in his last iteration. Hopefully he will have put it in this version. Pramila Jayapal's bill does have that provision. So it's a totally different funding mechanism that could work to the advantage of hospitals like Olympic.
Right, and the Olympic administrator is the former CFO, and the one before him was CFO, and he was clear that global budgeting could work. And our question is, let's see more about global budgeting. There are a lot of different ways to operate that, and we want to see that before we get on board. We can't afford to jeopardize the rural hospitals in Washington over something we're enthusiastic about, but the money isn't there for it. So that's a real concern.
So the gauntlet has been laid on the table. But isn't it, what a wealth of people of great knowledge and enthusiasm and devotion to all of these issues. I want to thank all of you for showing up and sharing with all of us this. And I hope the audience got a great deal of new information and maybe reminded about how important this issue is. So with that, we really are just after 8:30, and I don't want to hold anybody up, but if anybody is sitting on something they want to say really, fast, go ahead, because Allison hasn't cut us off yet. It's reset now.
I have something I was going to say. There was a question in there about if Canadians are coming down now like they were years ago to get care here, but they're not anymore because up there they used to have longer wait times for anything, especially surgery, total joint replacements, and they were coming down here for that. But it's so expensive here, they can't afford it. And the wait times have really improved up there. So,
and I was in Palm Springs last year when COVID hit, and the Canadian government, there's lots of Canadians in Palm Springs. And and a couple of weeks into it, early March, about this time, the Canadian government let all their citizens know that their healthcare was not going to work in the United States anymore.
Right.
And there was a big sucking sound in Palm Springs. All the Canadians had to go back home. So, yeah.
The wait times is a myth that we need to combat. The truth is, if you've ever tried to schedule surgery or something here, you know that there are long waits often. And in fact, we have longer waits than many countries.
Well, and plus people that don't have insurance or at that tipping point, they don't get care. So they're not even, they don't even have a wait time. They don't even get care.
Yeah, sometimes the wait time is years.
Mother lived to be 100. She got great care up there. I mean, if you needed it, you got it, but you did have to wait. If your knee didn't really need surgery yet, you have to try physical therapy or something first. So no objection to that. We're kind of nice, happy here anyway, I think.
Yeah.
I have to jump off, but I just want to say super quickly for anyone who's still listening that we need to get our entire congressional delegation to sign on to the State-Based Universal Healthcare Act that Representative Rokana is going to be putting forward that David mentioned. So wherever you are around the state and your congressional district, make sure you're pushing your member of Congress.
Excellent. Yes. And it's St. Patrick's Day when the bills are going to be announced. So happy St. Patrick's Day.
Thank you, everybody. It was great to see you all.
Thank you so much. I don't know how to thank you more, but
thanks everyone.
Thank you for doing this.
Good night. And if you need any information, you can contact. I think my email was in the chat.